Okay, so I'm going to be discussing pH associated with CTD, and I think this is also a very, very fascinating area. All of us as pulmonologists do tend to see a lot of patients who have connective tissue disease, and the challenge is to really see what is the type of pulmonary artery hypertension, which group does this patient fall into, because the treatment strategy will vary very much depending on the group the patient falls into, as we've been seeing in this lectures throughout the day. So I'll start with this case. This is basically a 40-year-old female who presented with progressive dyspnea for the last 4 years. She had some history of Raynaud's phenomena, bruised discoloration of the nail during the winter months for the last few years. There was palpitations off and on, dry cough for 6 months, and swelling of the feet for 15 days. She was initially being treated with asthma and then was thought to have coronary artery disease. Her ENA profile, anti-UN1 RNP, was positive. Echo showed PH with TR, and there was a mild restrictive defect. So based on this, what would be the possible diagnosis? And I could ask our panelist first, Dr. Jayalakshmi.
It's a long press.
Hello. Yeah, so with Raynaud's, young female, swelling of the feet, breathlessness on exertion, UN1 RNP positive. So this could be scleroderma, systemic sclerosis, or it could be a mixed connective tissue disorder.
Yeah, so one would think of, because of Raynaud's phenomena and some ENA profile being just borderline positive, that it could be a connective tissue disease. Dr. Sunil Kumar, any comments from your side?
Yeah, a young lady with Raynaud's and ANA profile. Of course, we would clinically want to know what more other features have, but definitely the suspicion would be in favor of a connective tissue disease here. And the ANA profile showing anti-U1 RNP positivity is more in favor of a mixed connective tissue disease, at least serologically, because that's the definition of mixed connective tissue disease. And if I can take 30 seconds, the last case which was presented had only SSA positivity, so I think that was an overlap disease rather than a mixed connective tissue disease. So yes, clinical diagnosis would start going in favor of us.
So this is the X-ray of the patient, and any comments from the panelist? Dr. Parag, anything you'd like to say?
So there's a prominence of bilateral, lower lower zone interstitial markings and a reduction in the lung volumes. That is what I feel. Anything
about the pulmonary artery?
Nothing. There's a little bit of cardiomegaly, if I can kind of appreciate from here, and no, I don't think the PA is very kind of prominent that way.
Okay, so from the X-ray point of view, one doesn't really look at or is able to make out a very large pulmonary artery. The lung fields look normal. There's a little bit of basal haziness, but that could be non-specific, and there's no decrease in lung volumes as far as the lung is concerned. This is the ECG of the patient, and any comments from any of the experts as far as the ECG is concerned? I'll just be a little quick because we are actually almost 1 hour late, so I can see the sort of organizers pleading that please hurry up.
So it's sinus rhythm, right bundle block with right axis and right ventricular and right
Correct.
axis deviation.
Right. So this patient had a CT also. This is the CT scan of this patient. Any comments from as far as the CT is concerned? So there's a significantly dilated pulmonary artery, and if you look at the esophagus is also looking big, and there really doesn't seem to be any evidence of thromboembolic phenomena. The CT, the lung windows of this patient, I don't have the whole cuts, but by and large don't really suggest interstitial lung disease. So this patient had normal lungs and no left heart disease. Would you ask for right heart catheterization? What comments from the experts, comments from the panelists, and then I'll ask Dr. Tala what would he say. We have large pulmonary artery. Why do you need to do a right heart catheterization? You have some degree of the patient. Echo showed just moderate TR. I didn't have the detailed report, so I didn't put it up.
So if we have a good colleague, liaison, and the cardiologist is open-minded about doing an RHC, it's always worthwhile getting it done.
So I think we discussed, and if you're looking at CTD related ILD, as I'll come to later on, it's important to get a right heart catheterization because CTD ILD is one type of an ILD. CTD is one type of a disease which can present with all types of groups as far as pulmonary arterial hypertension is concerned. So in CTD, it's important to see what is the group your patient falls into. And another important thing to remember is it can be more than one group at times, which actually makes it more and more difficult. So this patient did have a right heart catheterization. This is the data of the right heart catheterization, and maybe I'll ask Dr. Talha if he has anything to comment. The pulmonary artery pressure has been highlighted.
Okay, so the RA pressure is mildly elevated, the PA pressure is severely elevated, but still below the aortic pressures. So that's a good sign for the patient. So what are the numbers on the right? Acha, with O2.
With oxygen, this is
Yeah,
oxygen.
with oxygenation, I would say roughly similar PA pressures. The pulmonary capillary wedge pressure at rest is mean of 14, which is still acceptable, and your left ventricular end diastolic pressure is 14, so they both match. And the transpulmonary gradient and the PVR are significantly elevated. Again, there is a shunter undone. QPQS is normal, meaning there is no significant intracardiac shunting with a normal cardiac output. Sorry, it's a very busy slide, so I'm just trying to make sure. Yeah. So severe pulmonary hypertension, but still subsystemic PA pressures with a high PVR and normal pulmonary capillary wedge pressures.
So with this right heart catheterization, what would be your diagnosis from the panelist point of view and then maybe the experts?
Yeah, precapillary pH.
Precapillary pulmonary arterial hypertension.
Absolutely. So it all points towards precapillary pulmonary hypertension.
So which group would you put it in? Group 1.
Group 1.
So do you have a patient with
1.4.
1.4? Yes, exactly. 1.4 would be the ideal. Any comments from the rheumatologist in terms of how?
No, sir. At this point of time, I would go with that. I don't have any other differential or anything to add to.
So I think the important issue here is that when you have a patient with connective tissue disease, it's important to remember that it is actually a mixed bag. And you have a CTD PH, which may have an interstitial lung disease picture, which we see very often, but it can present with heart failure, and that's why right heart catheterization is important, because it can also have left heart disease, and it can also have CTEP along with group 1. So you can have group 1, group 2, group 3, group 4, and even group 5 as far as CTD ILD is concerned. And that, I think, is the reason why it's important to really focus a lot on your pulmonary arterial hypertension that occurs because of connective tissue disease. It is not that uncommon, and if you look at data, the most common that we tend to see is scleroderma associated pulmonary arterial hypertension, much more common. It does happen as for in patient SLE, mixed connective tissue disorder, much more rarer in rheumatoid arthritis. But like I said, you can have all the groups as far as the WHO-PHA group is concerned. As far as scleroderma is concerned, most of them can occur in SLE, and predominantly group 3 in the other connective tissue disease. So the question that I have I'm going to ask the panelists first, and then I'm going to ask the rheumatologist. In your experience, how common do you see CTD-PH, which is not ILD related?
So we see much more of CTD-PH with ILD related.
Because as pulmonologists, we tend to see much more of that.
Yeah, than the CTD-PH without the ILD. But the suspicion comes mainly with the hypoxia or the symptomatology and the 2D echo. So we do a routine 2D echo and a follow-up. So with that we come to know, but we don't see it so commonly as with the ILD.
So sometimes patients come to you with breathlessness, which seems to be related to suspicion of having an underlying lung disease, and often you think of this patient has sleep apnea or some other lung problem, But often it's important to keep in mind that it could be a primary group 1 pulmonary arterial hypertension occurring in CTD. How common would...
In our situations when ILD is there, I think the major hurdle is that whatever ILD is present, it is considered that it is a part of it, whatever is happening to the pulmonary arteries. So I think to understand that what is out of proportion word, which is used very frequently, we need to have some clinical acumen to be put into place at that point of time, because in systemic sclerosis there is a problem in the chest wall, there is a problem in the lung, there is a problem in the diaphragm, there is a problem in so many things that what is causing is very difficult, the breathlessness. So I think the index of suspicion needs to be very high and need to drop it to look at that it's echo has to be done very frequently. Like in last case we said every yearly echo has to be done, but most of our patients, they are doing rheumatologically well, lung-wise well, but breathlessness is not going away. I think that's the point which need to consider, especially if you have systemic sclerosis related ILD.
So I think systemic sclerosis related dyspnea, let's say, forget ILD.
Say dyspnea.
Systemic sclerosis related dyspnea can be multifactorial.
Correct.
It can be related to
Sorry.
diaphragmatic weakness, muscle related issues. It can be related to chest wall tightness. It can be related to underlying interstitial lung disease. But often one should keep in mind that it can also be related to pulmonary arterial hypertension, which could be a group 1 related problem itself.
Correct.
So sometimes you may have ILD which is very little and which does not explain the dyspnea per se. The lung function, the forced vital capacity may be more than 70% of predicted. The patient may have dyspnea which is on minimum activity, 6-minute walk test may be very low. In such a situation, if you have a PSS related dyspnea which is out of proportion and the ILD doesn't seem to be very strong, very much, it's important to keep in mind that you're looking at something which is outside the lung parenchyma. It could be vascular, it could be related to any of the groups, like I've said, and it could also be something which could be chest wall related.
So I think in my practice, CTD PH is the most complex and the most annoying diagnosis that I have to deal with, because as you rightly said, one CTD can have major different kind of mechanisms. Unfortunately for me, even after doing a right heart catheterization, I may not be able to tell you which one's more, because say this is CTD ILD or CTD PH, it's still going to tell me that it's a precapillary PH. I won't be able to tell you anything more, based on, you're not going to come out wiser after doing this right heart catheterization.
Correct. It just gives you an idea that you need to look at the entire picture in
Correct.
one go, in terms of looking at the clinical profile of the patient, looking at the other parameters, which could include a cardiopulmonary exercise testing, which could include looking at the lung function, the 6-minute walk test, the CT scan.
I think
and
you
then
very
taking a
rightly
holistic
said that
opinion.
CPAT is very essential in these cases, because that gives us an idea whether it is a muscle component
Correct.
happening, is it a gas exchange which is troubling the patient, is it the cardiac system which is failing, or is it the respiratory system failing. One more condition where they come, Randeep, is that they are doing fairly stable and they come and get admitted with hypoxia in the night in an emergency. And in the ICU, the diagnosis is an acute exacerbation of the ILD, which is actually heart failure, which has happened because of the pulmonary hypertension, which has come probably precipitated by an infection in these patients.
And often
then
if
they
you
go on.
don't look at the CT, get a CT done, it shows diffuse ground glassing,
Absolutely.
which is more of
That's
fluid
acute
overload,
A.
and you will say this is more of acute exacerbation of ILD. The patient lands up with steroids, goes on to scleroderma, renal crisis, and you start having other issues. So I think you have to be very careful to be sure of what you're actually dealing with.
As a rheumatologist, in our experience, we see more, maybe 1 to 2 cases coming per month, and this is largely due to screening of our own patients, particularly the scleroderma, as rightly mentioned, that we have a protocol of annual screening. We do that. In fact, any other connective tissue disease, like the previous case where you have an MCTD, but you have some overlapping features of scleroderma. The dilated esophagus was there on the CT. Again, the screening program changes to an annual, irrespective of what the primary disease is, if there is an overlapping feature of scleroderma. And then, of course, we get referrals from our cardiologist colleagues when there is no explainable cause. We have a good PH program, and we often get referred just to make sure that they are missing something clinically and not just relying on an ANA screening test. And of course, the pulmonology colleagues in all cases of CT-ILD, where there is some confusion what we have been talking about, the challenge, which group the pulmonary hypertension belongs to.
So I think the first take-home message is remember that CTD-related PH can present in any group. And therefore, when you're looking at treatment, you must look at which group does this patient fall into, which is the predominant group. Because as we discussed before, your treatment strategy could vary from just giving treatment from ILD point of view, immunosuppressants being aggressive, to treatment with pulmonary vasodilators, dual pulmonary vasodilators, to no pulmonary vasodilators because you may be causing more harm, or it could be an underlying CTEP for which treatment per se would be required. Madhukar, you wanted to say something?
That has been absolutely answered. Two very clear-cut messages to the audience. I think the CTD ILD is the one disease where combining CPAP with right heart catheterization gives us a valuable information. So this is the group where I usually practice combining CPAP with right heart catheterization, giving a clear-cut classification. And the second, as Dr. Talwar sir said, when the patient with CTD ILD comes in the emergency, right ventricular failure should be the one differential we shouldn't really miss out. Thank you so much.
Thank you. So just one question I have for the rheumatologist, and the next slide is based on that, because if you start looking at the data, and this is data predominantly from China, Japan, and from Taiwan, it suggests that in Asian population, SLE also does cause significant degree of pulmonary arterial hypertension. So unlike what we see in the Western data. So any comments from the rheumatologist? Are we seeing more of lupus-related and MCT-related pulmonary arterial hypertension as compared to what is seen in the West? Because there is a variation in the registry data if you look at data from China, Taiwan, Japan as compared
So,
to
I think in South Asian population, we do see more lupuses, and we see more of aggressive lupuses. So the lupus in Western population or in Caucasian population is not as aggressive in terms of the renal involvement or the myocardial involvement as compared to the Asian population. And when I was at Singapore, we saw, I was amazed to see the wards being filled with sick lupus patients. So that was one learning point, that we definitely see lupus with pulmonary hypertension more, but I wouldn't say that it is more than the scleroderma subgroup. So whatever scleroderma we see, if you compare the two, you still see scleroderma associated pulmonary hypertension more than lupus. But yes, compared to the Western population, lupus associated PH is more in the Asian population.
Yeah, so
This
that
must be right heart cath studies, no?
This is right heart cath studies, yeah.
Because otherwise in systemic sclerosis is the only condition where you will give anti-PH drugs without right heart cath.
Correct. So the issue here is that I was trying to point that one is trying to make is that let's not focus only on scleroderma. In Asian population, if you start looking at the data, MCTD, SLE also can present with pulmonary arterial hypertension, which is relatively less common if you start looking at the Western data.
I just wanted to ask Dr. Sunil Kumar Singh, like how many SLE patients are APLA positive, because there is a high risk of thrombosis. So do we see pulmonary artery obstruction in these patients?
Yes, we do see, and we always have to keep it at the radar. If you are dealing with a lupus with pulmonary hypertension, then doing an antiphospholipid syndrome antibody, all the three, anticardiolipin, LACA and beta-2 glycoprotein, and thinking about the embolic episode is definitely.
Okay, so I'm moving on from here to what we see as pulmonologists, and we see this whole issue of what the three overlapping worlds. We have the whole issue of pulmonary arterial hypertension, one world of that. We see a lot of interstitial lung disease, and then the rheumatologists see a lot of CTD, and we're talking of this overlapping world today of what we call PH, CTD, and this issue of CTD, ILD, PH, where it becomes very challenging for us to really try and differentiate between the three groups. So the issue that I'm going to ask the panelists is, what do you think are the risk factors for pulmonary arterial hypertension that you would look forward or look at when you're trying to look at your patient with CTD? Any risk factors that you think are more common, and then we'll ask the expert.
So as Sujit said, so if you have an underlying ILD, again there will be an issue when you have to treat the pH in CTD. So that becomes a much more complicated issue compared to CTD pH without ILD. So that would be one of the factors that we see.
Any other clinical parameters which may tell you that this patient has a higher chance of going on to develop pulmonary arterial hypertension in underlying CTD, serological markers? I'll just
I think
run
that's
through
the
that
important thing. The
and maybe you'll ask the
rheumatologist.
rheumatologist to see that, but
Yeah.
there are certain risk factors, could be serological, they could be clinical, and they could be related to cardiological factors. So maybe the rheumatologist can also add on to that. We have raised,
The important one here is, sir, the presence of Raynaud's phenomena with digital ulcers as a clinical risk factor, and telangiectasias. They have been clearly shown to be a very important risk factor for development of. So if there are telangiectasias, then, and that is what belongs to the previously called CREST or the limited cutaneous scleroderma, where your screening and the index of suspicion for pulmonary hypertension would be high. And from the serology, I have often found U1RNP. We have seen in the previous case also, and even in this case. So U1RNP is an antibody which even before it was reported, as I saw the patients, I always felt this U1RNP is doing some mischief when it is coming to the pulmonary circulation. And Rho, SSA antibody, which was there in Dr. Deepak's case. So these two antibodies are notorious for development of the risk of pulmonary hypertension. Yeah. So anticentromere antibody definitely with the telangiectasia in limited cutaneous scleroderma, definitely it's a risk factor.
anticentromere is one of the strong risk factors.
Risk factor. It goes with the telangiectasia and the limited cutaneous scleroderma.
So I think here, just to give you an idea that if you have features which are clinical, severe Raynaud's phenomena, multiple telangiectasia, if your NT-proBNP is high, this is another thing that one should look for markers, which may give you a suspicion that you are dealing with possibly some degree of heart involvement or vasculopathy. Then of course we have serological markers which were already discussed, anti-UNRNP, anti-Rho, and of course pulmonary risk factors which may be present. Since we're talking of scleroderma itself, there are criteria which are basically clinical on examination, a lung function, if you have a low DLCO, which we saw in one of the cases, DLCO being out to proportional, which is lower side, and the FVC by DLCO more than 1.6, and of course features on echo and cardiac catheterization, biomarkers, antibodies, all are those which will help you in making or suspecting that this patient may have pulmonary arterial hypertension. I'll just quickly run through the pathophysiology because I find it very fascinating. Pulmonary arterial hypertension and CTD actually have a huge correlation with them. It can happen with an immune-mediated pulmonary vasculopathy, which can be autoimmune endothelial dysfunction, dysregulation, and progressive pulmonary artery remodeling. So you have one pathophysiology which is an immune-mediated pulmonary vasculopathy. Then you have an ILD-driven pulmonary arterial hypertension, fibrosis, vascular obliteration, which is what we see more often. But then you can also have a cardiac involvement, the post-capillary pulmonary arterial hypertension, myositis and mixed connective tissue disorders tend to have that more, myocardial and pericardial involvement, left ventricular diastolic dysfunction, elevated left-sided filling pressures, and these are very important because this can also happen as far as your CTD is concerned. And of course, then you can have the thrombosis and vascular occlusion as we discussed in Aplas syndrome. You can have prothrombotic states related to autoantibodies, endothelial activation, and recurrent pulmonary vascular thrombosis. So all the groups can actually be present as far as CTD-PH is concerned, and you can have multi-system and overlapping mechanisms. So if you are going to look at your patients and keeping this in mind that the pathophysiology is so complex that you can have all groups, how do you screen your patient? What should you do in terms of screening these patients whom you suspect may have pulmonary arterial hypertension related CTD? Because this becomes very important, and then when you screen, then how do you decide which group the patient is in? So again, to the panelist, maybe Dr. Kapil can really, so what screening would you really suggest, and is there something that can be done?
So I don't, so apart from the echo for a certain group of patients, the right heart cath that we are talking about becomes more imperative in our practice. We underuse it because
but you do all right heart cath in all your patients?
No.
So how will you decide which patient should go on to do a right heart cath in a CTD suspected patient, CTD patient suspected to have pulmonary arterial hypertension?
So the group 1 patients?
screening tool will remain echo only, no?
Echo. So,
So
apart
when
from
you do an echo, so again,
Every
maybe if the rheumatologists have anything to suggest.
For scleroderma, we have a detect algorithm in place which is quite validated and used internationally very well. So
Do we have this detect algorithm for systemic sclerosis, which we screen the patients to look
So
for the
this
risk
is the detect
factors?
algorithm.
Yeah.
Detect algorithm actually works on 2 steps. And I think if you're looking at your patients, it's important to look at the detect algorithm. It's actually available as an app. You can download it and you can use it. And it looks at non-echocardiographic variables, and it's been shown to have a very high sensitivity and specificity. The DECT algorithm has a superior sensitivity as compared to the older guidelines. It looks at the FEVC predicted, DLC over the DLCO predicted, current and past telangiectasias, serum anti-centimore antibodies, serum NT-proBNP, serum urate, and right axis deviation and electrocardiography, which, if you remember, our patient also had right axis deviation. Based on this, it gives a scoring system and tells you whether there is a high suspicion and whether you should do an echocardiography. In an echocardiography, then you look at right atrial area and the TR velocity, and based on that scoring system, you then refer the patient to right heart catheterization. This makes it simpler for you in your patients to decide which patient to send for right heart catheterization, and it also really helps you to do it in a more selective manner, because all patients you will not send for right heart catheterization, and that is not actually practical. We've been discussing that since morning, that it's very difficult to do that. There's another screening system which has actually been done by the Australian Scleroderma Interest Group. Very, very simple. And I find this also very useful. And this looks at 2 parameters, the pulmonary parameters and the cardiac parameters. It looks at DLCO, less than 70% of predicted, and the FEVC by DLCO ratio, that is group component 1, and component B is the NT-proBNP. If any of these is positive, you should do an echo and look for other parameters to explain this, and then do a right heart catheterization. If both are negative, then the patient should be screened for every year for pulmonary arterial hypertension. So I think you have objective criteria which are available. It's not difficult to do in your clinic. One is available on an app, the other is very simple to do. You just have to look at a few parameters. So in day-to-day practice, I think it's important that you start looking at these parameters to see whether the patient has pulmonary arterial hypertension and whether to refer the patient for right heart catheterization. The 2022 ESC ERS guidelines also have that. They have, you're aware that they've changed tweaked the guidelines a little bit to the pulmonary vascular resistance being more than 2 Woods units as compared to the previous one of more than 3 Wood units. But here also, if you look at the guidelines, they look at low, intermediate and high risk based on what is known as a 3 strata model, and subsequently on follow-up they use the 4 strata model. And again, what they use is basically looking at various points which are assigned, WHO functional classification, the 6-minute walk test, the BNP or the NT-proBNP, and based on that you can again look at how to really classify your patients into a risk stratification, which is not only for the diagnosis point of view but trying to look at the risk point of view. Now let's move on to let's change gears a little bit, and this is a patient we saw last week. This is a 61-year-old male. He was symptomatic for the last 2 years. There's a history of Raynaud's phenomena, skin tightness over the fingers, there's shortness of breath. He came with hypoxia. His room air saturation was only between 85 to 88%. His echo report said left ventricular ejection fraction of 50%, pulmonary artery systolic pressure 81 millimeters of mercury, and there was grade 2 left ventricular diastolic dysfunction. The dilemma that we had was that does this patient have occult heart failure? He has group 1 disease because he has pulmonary arterial hypertension, but is there underlying group 2 disease also? Systemic sclerosis patients frequently develop heart failure with preserved ejection fraction due to myocardial fibrosis. So again, to the panelists, what would you do in such a situation?
We'll do MRI. Myocardial fibrosis is best picked up by MRI.
Okay, but that won't really tell you whether that is contributing to the pulmonary arterial hypertension. You would still probably need to do a right heart catheterization.
Yeah, so
Also,
but what will you do in the right heart
But what I wanted to tell here a message was that the MRI is no longer no in respiratory medicine.
So MRI is very important.
It has become very big now, and they are able to give us much more information, and of course without the radiation risk. So I think my idea was that if you are looking for a myocardial fibrosis, then that's a very good investigation to go ahead with.
Dr. Tawad, can cardiac MRI gives important information about right heart physiology if you ask our radiologist to do that?
So can it replace right heart catheterization? I think that is the question. Because all of us would be very happy if it could do
Yes,
that.
I will also ask you this question.
As today, as we sit right now, I don't think it's enough to replace right heart catheterization, because again, these are just numbers: RVEF, right ventricular strain, RV insertion, point fibrosis. These all point towards prognosis, but they cannot replace the actual number. There are dynamic phase mapping that you can do with cardiac MRI, but still you cannot replicate the kind of information you get. There are certain groups which are working on trying to estimate pulmonary vascular resistance on cardiac MRI, but again, not. These are data from smaller cohorts. It's not been validated in across larger cohorts. So not able to replace, but I think this would be a good thing to. This case would be a perfect case to do an MRI with a right heart.
So I'll add to this, Randeep. 25, when we have Collins Church coming from Scotland, and then on PH, he said that there is a movement going towards where you can actually get away without right heart catheterization and dynamic mapping. All it requires is to be put up there, and they showed the equipment also to us. So that's why we were interested that if it's not today, maybe in another 4 or 5 years it will come.
That's why I said today, as of now, we don't have it. But yes,
But their center is doing, they are the basic referral center for entire Scotland in Glasgow.
So 10 years ago when I was in, not 10, maybe 12 years ago when I was in Pittsburgh, we started using dynamic phase mapping, and that's when we churned out 4 or 5 papers on RV and PH. But again, that sort of grew and then reached a plateau. It's not really percolated into India yet. I don't know if KDA has it. We don't yet in our institute have dynamic phase
mapping. But something to look forward.
Absolutely.
In future.
It's something which is evolving. There is a lot of interest. Barts Hospital in London is doing a lot of work on this. And they have a collaboration with AIMS, and they do a lot of work on thalassemia. So do cardiac MRI to look at iron load in patient thalassemia, and they can do an MRI in 10. They have a protocol where your MRI takes only 10 minutes.
And for sarcoidosis, to rule out cardiac involvement, cardiac MRI is the standard now. We don't do cardiac
sarcoidosis now. MRI has actually changed it. In the past, one would talk of endomyocardial biopsies and looking at all of that. Now we just do an MRI. So I think that in the future, MRI would actually really give you a lot of information as far as cardiac function is concerned. But as of now, probably you would actually do a fluid challenge.
So a right heart cath with a good fluid challenge.
So as of now, a fluid challenge is something that will really help you to unmask a left ventricular diastolic dysfunction. So if you have a suspicion of left heart disease, if you are getting a right heart catheterization done, please make sure that a fluid challenge is also done, because that will help you. And if you have a pulmonary arterial wedge pressure rising to more than 18 millimeters post challenge, the patient gets reclassified as group 2, and that's very important again, like I said, in your CTD PH, because that really tells you whether you're dealing with group 1 alone or it's a combination, and then you will land up wanting to give these patients diuretics. The second issue that we see more commonly in our setup is that this is another patient. She has been on follow-up for many years now. She's a patient, 39-year-old lady who had pulmonary tuberculosis almost 8-10 years ago, treated, has sequelae of that. She has hypothyroidism. She has history of Raynaud's phenomena, shortness of breath, chest pain, and cough. She's had 2 hospitalizations in our hospital for the last 2 years with respiratory failure, currently on home on long-term oxygen therapy, and also uses intermittent BiPAP. Her 2D echo shows left ventricular ejection fraction of 55%, pulmonary artery systolic pressure of 42 millimeters of mercury. The dilemma is this patient having group 1, group 2, or both as far as the CTD related ILD is concerned? Is there pulmonary arterial hypertension out of proportion? So again, to the panelists, how will we actually differentiate between group 1 and group 2? And this is what we have to do in day-to-day practice every day. So this is something that we need to really take a call on, because as was mentioned in the beginning, if it's purely group related to group 3, then your vasodilators are not of much use, except possibly sildenafil and new data.
In group 2, it will deteriorate.
In group 2, it will deteriorate, but group 3, suppose you have purely a group 3 patient, what will you do as compared to a combination of group 1 and group 3? So how will you differentiate a PH-ILD from a CTD PAH?
Not without right heart cath. Not without right. Sorry? Gas exchange will be seen in both of them. Only the cardiac limitation will come if it is primarily because of the group 2. Cardiac limitation will
becomes
come.
very, very difficult on
But
CPAP
it becomes difficult.
Actually, I think here it's basically, again, like you said, looking at whether it's proportionate or disproportionate. Group 3 is basically defined as severe parenchymal disease with modest pulmonary arterial hypertension. In Group A, you have mild pulmonary parenchymal disease, but out of proportion of severe pulmonary arterial hypertension. But this is basically a big challenge, and this is something that we see in day-to-day practice. There have been various criteria which have been looked at. One is looking at the lung function. If it's mild restriction, disproportionately low DLC, as we saw in one patient, goes more in favor of Group 1 maladaptive. If there's a severe restricted effect, it goes more in favor of an ILD. And then you have imaging, which can sometimes tell us if the degree of ILD is correlates with that. The patient which Dr. Talwar showed had very little ILD, so unlikely that that degree of ILD was causing pulmonary arterial hypertension. And of course, the hemodynamic parameters can also be helpful. But I think it's very, very important that you to remember that you have a respiratory phenotype and you have a vasculopathic phenotype. And for us to really differentiate and tease out the difference becomes a big challenge. And you really need to start looking at what are you doing in terms of these two dominant phenotypes that we see in day-to-day practice. What is the underlying process? What is the pathophysiology? What is the lung function, the hemodynamics? And therefore, the criteria itself tends to become very, very, criteria to treat becomes very different. This I won't go into because this is already being...
So can I interrupt here, Dr. Modi?
Yes, yes.
So the scan in the X-ray looks like fibrosing mediastinitis in the second case, and then it actually becomes Group 5 pH. So is it still?
I didn't
possible?
get the. What did you say?
The X-ray and the scan, because of the old history of tuberculosis in the second case, it looks like fibrosing mediastinitis. Even the PA pressures are high, and so then it becomes a Group 5.
So if it is fibrosing mediastinitis, it further adds on to the complication that you're having.
It becomes a Group 5.
And you're going to have a mixed pattern. And that becomes even more challenging in terms of your treatment. The other issue, of course, is to really look at pulmonary veno-occlusive disease. This also is something which you see as far as scleroderma-associated pulmonary arterial hypertension is concerned. We discussed that, and the importance of this is that if you are going to give pulmonary vasodilators, it can lead to pulmonary edema and worsening, which was what Dr. Madhukar also mentioned, and this is also an important thing to keep in mind. So I think when you are looking at CTD-associated pulmonary arterial hypertension, you have to have a high clinical suspicion. You have to have some baseline tests done, a screening echocardiography, parallel evaluation for contributing factors, which would be an HRCT, echocardiography, a VQ scan, a CTPA if you're suspecting pulmonary thromboembolism. Look at other biomarkers, which could be autoantibody profile, anti-pro-BNP. Think of a right heart catheterization. I think it's important to get that done. Then classify your patient. Which group does this patient belong to? Because each group can be there. And then have a multidisciplinary discussion in terms of what is the best form of treatment that you want to give to your patient. The second part that I had to talk on also is on the management. I don't know whether we have enough time. I'll just quickly run through the slides because we're running very, very late. So I'm not going to discuss most of the trials. We all know that we have this whole class of drugs, the endothelin pathways, the prostacyclin pathway, the nitric oxide pathway, and more recently the actin or the TGF-beta pathway. I'm also not going to go through the various trials, but I think all of these trials also looked at CTD-associated pulmonary arterial hypertension as a subgroup. They looked at predominantly Group 1, but CTD-associated pulmonary arterial hypertension was also as part of the subgroup. And as was mentioned, the AMBITION trial clearly showed that upfront combination of ambrisentan and tadalafil was superior to giving monotherapy, and this is also true for CTD-related PAH. We've had data basically on tioprostenol also, which has also shown improvement in 6-minute walk test and reduction in anti-pro-BNP. Again, I'm not going to go into this. There are problems as far as prostacyclin pathway agents are concerned. In scleroderma patients, if you're giving it subcutaneously or intravenously, they don't tolerate it that well. And selexipag is the drug which one would tend to give. And the Griffin trial did show in the subgroup analysis that CTD patients did well. And the same is true with sotorasib. which again shows importance. But the point that I would also like to make, that don't only look at pulmonary vasodilators. You are looking at a disease which is an immune-mediated disease. So also focus on the immunosuppressive therapy. And even if you have pure pulmonary arterial hypertension, there is a role of giving immunosuppressive therapy, and patients often respond to immunosuppressive therapy. And again, I'll ask Dr. Sunil Kumar for his comments as far as this is concerned. If you have an SLE or patient with scleroderma with PH and let's say doesn't have ILD, would you still consider immunosuppressive therapy?
Yes, sir. So there the classification is simple. If you have SLE or mixed connective tissue disease, then these two diseases have been shown to be responsive to immunosuppression. And I would definitely consider immunosuppressive therapy purely for the pulmonary hypertension also. And when it comes to scleroderma, time and again, whether it is cyclophosphamide, MMF or rituximab, there has never been a convincing evidence that immunosuppression can alter the course of the disease, except that there are two papers now. One is the rituximab paper which you have mentioned here, which showed just stability. It didn't show much of improvement, but there was a trend towards improvement. So I think people will continue to explore given the the mortality with pulmonary hypertension. And there is an October paper where the groups have been classified, very nicely done paper, into immunosuppressive therapy alone and immunosuppressive therapy with vasodilators. And irrespective of where the patient belonged to, SLE, MCTD or scleroderma, they were able to show that with immunosuppressive therapy, there was a significant improvement.
Correct.
So that's very heartening that even for scleroderma, but the important point is that immunosuppressive therapy is only cyclophosphamide. So everything has been proven with cyclophosphamide only. That is what we have to keep in mind. MMF has not yet shown that kind of benefit.
So I think the data predominantly is high-dose steroids and cyclophosphamide. Some data emerging as far as rituximab is concerned. More data as far as SLE is concerned. For scleroderma, the data is less likely. But as you mentioned, there is a paper published this year, which is a retrospective study which looked at the data of intensive immunosuppressive therapy. And if you look at the underlying CTDs, they looked at all groups. It's a small group, but they looked at SLE, mixed connective tissue disease, Sjogren's, scleroderma. And they showed that in those who were given aggressive immunosuppressive therapy, the event time survival, both in looking at all-cause death or lung transplant, was much better as compared to those who were not given aggressive immunosuppressive therapy. So I think it's important to keep in mind that along with your pulmonary vasodilators, you should also look at immunosuppressive therapy, because if you're looking at a CTD-related disease, the pathophysiology is such that there is immune-mediated inflammation occurring, a vasculopathy which is occurring, and therefore it's important to treat that also rather than just looking at pulmonary vasodilators. So I think that is what I would like to really point out, that there is data suggesting that immunosuppressive therapy may be useful and one should not deny the patient immunosuppressive therapy. Lung transplant is something that one would look at, but again it's important to remember that these are, and if you talk to your transplant surgeon, they're very reluctant to take your scleroderma patients because they feel that they do worse and the chance of rejection is high, and that's because of esophageal dysmotility. They have a hypertensive lower esophageal sphincter, therefore they tend to have more of gastroesophageal reflux, microaspiration, and therefore chronic lung allograft dysfunction and bronchiolitis obliterans is much more common in this subset of patients. So just finally rounding up, if you have a clinical suspicion of CTD, pulmonary arterial hypertension, dyspnea, increased loud P2, TR on cardiac auscultation, decreased DLCO, increased FEV by DLCO ratio, do a routine test, do an echo, look at imaging, and then if it looks like, use the DETECT score or the Australian scleroderma investigative group score, and then think of right heart catheterization. After right heart catheterization, classify your patients. It's very important to do that. Is it group 1, group 2, group 3, group 4, or is it group 5? And then based on that, you decide on the treatment strategy that you want to give, depending upon low risk, intermediate risk, high risk that I mentioned. And keep in mind that depending on the group, the treatment varies, and that is the important thing to remember. That if you have group 1, yes, pulmonary vasodilators will help. If you have group 2, you're looking at more of heart disease related thing, diuretics, blood pressure control, and left heart measures will help. If you have group 3, then you're looking at treatment in terms of treating the ILD, oxygen therapy. Group 4, you have basically looking at CTEP and therefore whether you want to send the patient for pulmonary endarterectomy or balloon pulmonary angioplasty is something that you need to look at. And if you have group 5, then you need to take a decision as what is the best way to treat. So I think what we need to look at, differentiate the phenotype, treat group 1 aggressively, look at if you have inhaled tioprostanol available, you can look at that as group 3 is concerned, and regularly screen your patients. I think that is also very, very important. And I think a collaborative work is required. You need to have a rheumatologist, cardiologist working with you if you really want to really look at this subset of patients, because these are patients who have multiple issues and they need a very close evaluation, unlike isolated idiopathic pulmonary arterial hypertension. Also remember that survival in CTD PH is inferior to idiopathic pulmonary arterial hypertension. A recent meta-analysis published in 2021 showed that the 3-year survival in them was lower than as compared to idiopathic pulmonary arterial hypertension. So I'll stop here, and I think any comments from the panelists or the experts, and then we can have any questions if there are any. There's a hand at the back there.
I have a question for you, Randeep. So is there a way to look at it that there is still inflammation moldering in rheumatic diseases? What is the role of PET scan?
So PET scan can show you if there is vessel inflammation. One looks at a PET scan if there is endothelial inflammation. If there's large vessel involvement. For small vessel involvement, it's not that useful. You could look at inflammatory markers, which may tell you whether there's ongoing inflammation. But I'm not sure whether they are
because
sensitive or
you have brought
specific.
a very good point actually, that when we have a CTD related patient who develops a pulmonary hypertension, we are not done with immunosuppression.
Yes.
We have to upscale the immunosuppression and then start the other things. But in most of the times, what happens is they have been on immunosuppressives for a very long time. They have already received cyclophosphamide in the past. वो तो उनको पहले ही मिल गई होगी 2010 में ही. तो अब तो उसके बाद की कहानी चल रही है. तो अब rituximab भी देना है उनको. Correct? So data, Randeep has shown that Ritux is already coming up and it is showing the data. But obviously Ritux is slowly acting. It's not like cyclophosphamide you have given and tomorrow we'll start seeing something. So it's very difficult decision to be taken at that point whether to upscale the immunosuppression, because these patients are already very friable at that point of time when we see them. So we really need a biomarker for that. So I have not looked into CRP. Is the CRP raised, or CRP is not a criteria to give cyclophosphamide?
CRP is not, in fact, a good point is that CRPs are usually not raised in the connective tissue disease that we deal with, either ILD or, so lupus characteristically, CRP should be normal. If you see a high CRP, you might start wondering something else is happening.
Okay, so that
CRP
means
not.
more work on this way.
Yeah, PET CT, that minute degree of vasculature, unless and until it's a pulmonary large vessel vasculitis, which we don't see in this CTD, we see in Behçet's and other things. So again, that is not going to be useful. And plus to complicate...
It will be useful when AI will be added to it. No?
Yes.
AI will come definitely in 5 to 7 years.
To complicate large vessel involvement, so for example, a patient with aortoarthritis,
they will be very beautifully able to demonstrate the PET scan images.
And sometimes if you are working up a patient with FU or fever of unknown origin, and you do a PET scan, it shows this thing, that this is related more to aortoarthritis.
Yeah, because that's what I said. In Takayasu, PET scan shows beautifully actually,
but
where
in small vessels, I don't think so unless, maybe like you said, AI
might be able to
AI is the buzzword
Life will
nowadays.
be somehow easier also in future.
Yes, you have a question there. Can we have a mic?
So my question is regarding the timings, because most of the CTD come up with they have the lung problem, they have the CTD associated issues and the pulmonary hypertension full of symptoms. When we we evaluate everything, whether to kick off with the immune suppression first, whether the ILD drugs for antifibrotics first, or the pulmonary hypertension, because two scenarios arise. Either they come in the next follow-up visit, they'll be either good and we do not know what has worked, or they will come worse and we do not know what they work. So what is the question is across the floor. What would you initiate first, whether to go with pH first, ILD first, the immune suppression first?
So I think the question here is, you have a patient who comes to you who has a CTD related pulmonary arterial hypertension but also has ILD, he has all three, and you have to start treatment. Would you start initially upfront with immunosuppressants?
So no antifibrotics upfront. in all CTDs, immunosuppression has to be the baseline standard therapy. From there, you build up your next level, what you want to do. I think systemic sclerosis has got guidelines to suggest that you can use antifibrotic right in the beginning, so when the lung functions are preserved. But that's putting us into trouble, because every patient at the age of 24 starting with an antifibrotic nintedanib going to take for next 25 years. It's like something bad. So I think immunosuppression always first, then comes the next thing. If the patient has pulmonary hypertension, I think then antifibrotics will not have a role. Anti-pH drugs and vasodilators will have a role. But yes, you have to at one point consider antifibrotic, but then I think we have to go very judiciously for that. I think Sujit is there. Sujit, what have you recommended in the guideline?
So before Sujit says, you have to show that there's progressive pulmonary fibrosis.
Yeah, sequential.
Sequential. So unless and until you show on immunosuppression, the patient has deteriorated, there is no point in adding. But the problem is your immunosuppression adequate? How much of MMF you are giving?
So it's very important to fully treat the disease.
Absolutely. Yes. So, and if we don't treat the disease, we are going to reap the, the burnt out disease, which is going to cause the symptoms, which I think are not treatable by the immunosuppression at that time. But I have learnt a lot that still don't give up on immunosuppression.
Yes. I think that is one take-home message. And secondly is, when you're looking at it, don't focus only on pharmacology. Look at pulmonary rehab, look at other things that you need to do. Your patients may do significantly better if you have a comprehensive package in terms of treating them rather than just medication. But immunosuppressive becomes the first line of treatment. Assess the response, then take a call on pulmonary vasodilators. If you think they would help, they may or may not help depending upon what is driving the pulmonary arterial hypertension. And if there is progression of disease based on the criteria of progressive pulmonary fibrosis, antifibrotic should be added. Any comments from the... Thank you very much. Thank you.